It's Friday, the 12th of June, and this is the Hot Topics podcast. Welcome to the Hot Topics podcast from MB Medical. Neal Tucker here, as usual, and I will be taking you through the next 20 or 30 minutes to update you with what's new in the world of the medical literature relevant to us in general practice, what you really need to know right now. So we've got 3 pieces of research today, but I'm also very excited that at the end of the podcast, we're going to have an interview with an expert in a skin condition that you might not have come across before called Epidermolysis Bullosa. This is an unpleasant condition associated with skin fragility, often present from birth with different levels of presentation, so it may be missed into adulthood. And this is brought to you in conjunction with DEBRA, which is a charity aimed at raising awareness and funding research into treatments for this condition. So I'll be talking to Dr Anna Martinez, who's a consultant paediatric dermatologist at Great Ormond Street Hospital and one of the national leads in this condition. So do have a listen for that. But first, we got 3 pieces of research as usual. 2, in fact, on the same topic, which is Finerenone, one from the New England Journal of Medicine and one from the Lancet, both from this week. And then another paper in the New England Journal of Medicine on retatruide, one of these new injectable weight loss medications that's been getting a lot of headlines in the last month, but this time looking specifically at the management of type 2 diabetes. Speaking of which, NB News first, and we've got our Hot Topics Diabetes for Primary Care course coming up next Thursday. That's on the 18th of June. That's a full day course. Join us for that. We've got our dermatology in primary care course coming up on Saturday, the 20th of June. So that's been updated with a range of new topics as well as the core stuff that we need to know for managing skin conditions in primary care. And then we've got a bit of a break over the summer. We'll be back in September with the live webinars. But if you do want a bit of a catch up, all of our courses are available on demand. Why not sign up for MB Plus, our subscription service, just over £300 a year. You can see all of those courses. You can come on all of our live webinars for the next 12 months as well. Loads of extras included. Do check out the website. Okay, on with the medicine. And let's start off by thinking about Finerenone. Have you prescribed this medication yet? Got any patients on this medication yet? It has felt a little bit niche up till now because A, it's only been for people with CKD stage 3 or 4 plus albuminuria plus diabetes, type 2 diabetes specifically, who are already on maximal other therapies such as ACEs, ARBs and SGLT2 inhibitors. And B, it may well have been specialist initiation only in your area, although I think that's probably changing. Locally to me now, it's been given the green light. GPs can start it as long as patients meet the NICE criteria. Even then, I suspect most of us won't have done that though, partly because of lack of awareness of the drug and partly due to lack of familiarity. You might be sat there thinking, well, what the hell is Finerenone and what does it actually do? These are fair questions. First though, I'll pose a different question. Why do people get CKD and why does it get worse? And until reading around today's research papers, I hadn't really realised that CKD and progression of renal disease, just like it would appear for every other thing that seems to go wrong in the body these days, it's largely driven by inflammation and then subsequent fibrosis. This in itself is driven by overactivation of the mineralocorticoid receptor. So as well as increasing sodium and fluid retention, that also has a pro-inflammatory and pro-fibrotic effect. This doesn't just affect the kidneys, it affects the heart as well, probably other parts of the body too, which hasn't really been explored yet. And that's one of the reasons why we see people with progressive CKD often dying not of end-stage renal failure, but of cardiovascular events. This is one of the reasons why SGLT2 inhibitors are useful. They reduce cardiac events. They're not just helping the kidneys. And of course, CKD is on the rise. As the lead editorial in The Lancet says today, the need is huge. CKD is the 9th leading cause of death worldwide and estimated to become the 5th leading cause by 2040. And that's likely an underestimate as a large proportion of cases are undiagnosed. the risk factors for CKD, particularly hypertension and diabetes. Also, the Lancet references things like heat exposure and other environmental factors are increasing as well. So we are going to see a big rise in CKD over the next decade, which then brings us on to Finerenone. So Finerenone is a non-steroidal mineralocorticoid receptor antagonist. So it's a bit like a Plerenone or spironolactone, but these are steroidal mineralocorticoid receptor antagonists, or MRAs. The difference is that these generally have a greater effect in the kidneys, and they're less likely to discriminate in the steroid receptors that they bind to, so you're more likely to get side effects such as gynecomastia. Non-steroidal MRAs, though, they have a different chemical structure that seems to fit the mineralocorticoid receptor more accurately, resulting in higher selectivity plus more effective blockade of the receptor. So overall, the effect is meant to be greater. This is particularly apparent in the context of inflammation and fibrosis. It's also notable that non-steroidal MRAs have a more balanced effect on heart and kidneys. The distribution of where they're affecting is more balanced between the two, meaning a greater reduction in cardiac inflammation and fibrosis than you might see with a steroidal MRA. So theoretically, this should help prevent cardiac events. So is Finerenone going to be the next big thing like the SGLT2 inhibitors? Well, it's already been shown to reduce the risk of renal and cardiovascular outcomes in patients with CKD plus type 2 diabetes. So that's a particularly high risk group, of course. Also benefits in type 1 diabetes, who of course can't have the SGLT2 inhibitors. It's demonstrated benefits in people with heart failure with preserved ejection fraction, which is, as you know, a particularly tricky group to help. But one group that hasn't been looked at in much detail is people who have just CKD without diabetes. So today we're having a look at two trials, and they're approaching this question from slightly different angles. So the first is in the New England Journal of Medicine, and this is a new randomized controlled trial specifically designed for patients with CKD and no diabetes. 1,500 participants in total, examined over 32 months. The second piece of research is a systematic review and meta-analysis in the Lancet, collecting existing published trials on Finerenone and combining them to, as they put it, evaluate the efficacy and safety of Finerenone across the spectrum of CKD. Both of these studies are funded by Bayer, which is the maker of Finerenone. It's just worth noting, but obviously that's no different really to most new research in new drugs. There are too many figures to simply read out in the podcast, too many results. So I'm going to give you the highlights. Let's start with the New England Journal of Medicine randomized controlled trial. So almost 1,600 adults with no diabetes but CKD with an EGFR of 25 to less than 90 plus albuminuria. So in the UK figures, you've got to have an ACR of 22.6 or greater. If it's more than 400-ish, then those patients were excluded from the trial. You've got to be pretty bad for that, right? Participants were already on a renin-angiotensin system drug, so already on an ACE or an ARB. That's one of the inclusion criteria for the study. The primary outcome was the mean annual rate of change in EGFR from baseline to month 32. And then they also looked at secondary outcomes, assessing kidney and cardiovascular outcomes as a range of different composites, which isn't ideal, but seems to be pretty standard practice these days. I'll give you a flavour of the characteristics of the study population. Average age was 54, which sounds really young, but that's because a lot of these patients had chronic glomerulonephritis. That's about half of the study population, while about a third have hypertensive or ischemic nephropathy, which is, I guess, what most of our older CKD patients in the UK actually have. Mean EGFR was 47. The albumin-creatinine ratio was under 110 for about 60% of those included. 2/3 were male, 56% were Asian, 39% were white. That's a really interesting statistic because we don't typically see that in UK studies, and it perhaps tells a story in itself about who is at the highest risk of severe chronic kidney disease, I think. But I should say also that this was an international multi-centre trial recruiting from all continents around the world. Last figures, 88% had hypertension, 10% or 11% actually had atherosclerotic disease, 18% were already on a diuretic, and 17% were on an SGLT2 inhibitor. On to the results then, and the mean annual rate of change in the eGFR from baseline to month 32 was minus 3.3 with Finerenone and minus 4.0 with placebo. So a 0.7 difference in eGFR per year. Apparently this is statistically significant. Initially, I'll be honest, I felt pretty disappointed looking at that figure, but it might well underrepresent the level of benefit and be better than it looks. So initially with Finerenone, the eGFR takes a bit of a drop, just like we see often with ACE inhibitors and ARBs, which doesn't mean it's not working. That's a natural part of using these medications. After this initial drop, further reductions should be attenuated by the drug. They should be less than if you weren't using the medication. And importantly, you don't see that initial drop with placebo, but then you also don't get that slower decline afterwards. And this pattern is exactly what they saw in the trial. The 20-week mark was the point at which the active treatment and placebo eGFR changes crossed, with the active treatment thereafter resulting in less decrease overall, and a bigger gap appearing to open up by close to 2 years, which was how long they actually followed up the patients for, even though they were only reporting really on up to month 32. This is important because although by their nature randomized controlled trials are short, really what we want to know about is how this and other medications influence CKD and its associated complications in the longer term. So while we're extrapolating a bit now from the data, it seems reasonable that Finerenone may give greater benefit in the long term than we see in the short term, and that rate of decline diverging further and further as the years go by. In other positive news, Finerenone reduced composites of kidney and cardiovascular events by 23%. That's when you're looking at all of it together. Heart failure, hospitalization, or death from cardiovascular disease clumped together as a composite, reduced by 40%. Interestingly, systolic blood pressure was 5 millimeters of mercury lower on average in the Finerenone group, diastolic 3, whilst it didn't change at all in the placebo group. And just a note to say that rates of hyperkalemia, which is what most of us would be a little bit worried about if we're starting an MRA, were slightly higher with the active treatment group. So 17% had a notable rise rather than 13% on placebo. So the difference is not that large. Otherwise, there was not much to separate the two arms in terms of adverse events. So that's lots of figures, and it's all very well being given kind of percentages about composite outcomes and things like that. But what does it all mean in the real world? And I think that is hard to gauge from hazard ratios and eGFR slopes, which then brings us on to the Lancet, which maybe helps answer some of that question in a little bit better, a little bit more manageable for you and I to think about. So this is a systematic review and meta-analysis. And I'll be honest, it really confused me to start off with. So firstly, it talks about assessing the whole spectrum of CKD and its associated etiologies. But of the 3 randomized controlled trials included, there were only 3. There's not that much data on Finerenone. Well, I say that, there's not much data. There was 15,000 patients worth of data. Anyway, of the 3 studies, 2 of them, the Fidelio DKD and Figaro DKD, which were by far the largest ones, they accounted for 90% of the data included. They had patients who only had CKD with type 2 diabetes. The third trial that was included was the one that I've just talked about, published in the New England Journal of Medicine in the last week. That really threw me for a while. I was like, how is this already included? But of course, they already have the data. It just takes a really long time to actually get some of these research papers out into peer-reviewed journals. So of the 15,000 participants worth of data they included, worth bearing in mind that that latter trial is the only 10% which actually had patients who didn't have type 2 diabetes. Nevertheless, we have a wealth of data here. So for example, the easy findings are looking at similar composites that we've just described in the New England Journal of Medicine paper. So things like kidney outcome, kidney failure, cardiovascular outcome, and kidney and cardiovascular outcomes lumped together. All of these showed reduction to varying degrees with Finerenone compared to placebo. They then went to look at how these outcomes vary within subgroups. So things like the presence of diabetes, the underlying cause of the CKD, the level of the EGFR or albumin-creatinine ratio, whether they're using SGLT2 inhibitors. And without going into all of these figures individually, because no one wants to hear that on a podcast, and to paraphrase the linked editorial somewhat, the treatment effects on kidney and separately on cardiovascular composite outcomes were consistently positive, irrespective of any of these individual features. So it's having an independent effect, irrespective of those different individual characteristics. It also gives a numbers needed to treat for the composite of renal and cardiovascular outcomes, which is 29. So that's much easier to understand than EGFR slopes or hazard ratios. And in these kind of research circles, in public health, in epidemiology, as we've discussed on the podcast before, a numbers needed to treat at 29 is considered pretty good. I personally prefer not to think about it too much these days because it just makes me feel a little sad. Overall, sounds like you and I will be seeing more of Finerenone in the future. Indeed, you may well, of course, already be able to or actually be prescribing it. The editorial concludes that this data should change guidelines and encourages a triple drug cardio-kidney protective approach with renin-angiotensin system blockers like ACEs and ARBs, SGLT2 inhibitors, and now non-steroidal MRAs as well, including in patients with CKD with no diabetes. The guy that wrote this has a really long list of drug companies that have paid him for some consultancy work or speaker fees at some point in his career. So I really wanted to call bull, S-H-I-T, on what he's saying, but I think the reality is that the data is pretty compelling. And at least for this group of patients who have got quite severe CKD, so their EGFR is lower and their albumin-creatinine ratio is markedly raised, actually we're probably going to see this triple therapy sooner rather than later. That's not to say that this is applicable to all of our patients with CKD. Most of our patients on our books with a diagnosis of CKD have that through virtue of a slightly lower EGFR, probably age-related. Their albumin-creatinine ratios are often entirely normal. And these are not the target audience. These are not people who are at huge risk of progression. But if we do have younger patients, just like in this study, then that is going to be much more applicable in a group that perhaps we could actually do a little bit better for. And if the researchers are right, and that we're going to see a 400% increase in the rates of end-stage renal failure over the next decade, then this is going to become increasingly relevant to all of us. Okay, third and final study today is also published in today's Lancet. Honestly, if this issue hadn't come along, I was struggling a little bit to find things that I wanted to talk about on the podcast this month. Anyway, I'm not going to lie, it's about GLP-1 medications, and I know we haven't talked about them for at least 2 episodes, so you're probably all getting withdrawal symptoms. But actually, strictly speaking, we're not talking about a GLP-1 receptor agonist today because it's actually a triple receptor injectable, GLP-1, GIP, and glucagon receptor agonist given by weekly subcutaneous injection. So this drug has managed to gain lots of headlines since the last podcast, as its makers, the American pharma massive Eli Lilly, who also makes tirzepatide, made a press release of the 2-year Triumph 1 randomized controlled trial involving retatruide, which produced a 30% decrease in mean weight when used for weight loss in people with obesity and or overweight who do not have diabetes compared with placebo. But that data hasn't yet been published in a peer-reviewed journal, so we're going to deal with that when it is. Today, they've published how effective retatruide is for type 2 diabetes management. You and I, of course, may be very restricted in whom we can prescribe injectable weight loss medications for obesity management on the NHS, but for type 2 diabetes, it feels like the door has opened. Loads of patients are now getting them, and we're often seeing really impressive improvements in HbA1c levels. What's really interesting about this study, though, is that they're not looking at retatruide as an add-on therapy. They are looking at whether retatruide could be used as monotherapy for type 2 diabetes management. Forget your metformin, forget your SGLT2 inhibitors. Just use this, with presumably the goal being to put yourself into remission, although of course you can't really call it remission if you're still on an anti-glycemic medication, and we all know that you probably need to stay on the medication to maintain the weight loss and maintain that remission. But let's park that discussion for now, because even the diabetes experts can't agree on it. If you've listened to the podcast before, if you've been on a recent Hot Topics course before, then you'll be familiar with the setup of these weight loss trials by now, and this diabetes one is just the same. So this one is a phase 3 randomized controlled trial conducted over 40 weeks, double-blind, placebo-controlled across the US, Mexico, and India. So it's not quite the World Cup mix. Adults had type 2 diabetes, which was inadequately controlled by diet and exercise alone, with an HbA1c between 7 and 9.5%. So in the States, they presumably still work on old units. That's 53 to 80 if you're in the UK. And they also had a BMI of at least 23. I know that sounds pretty low. And it was, because in the study, the average was actually 36. So 930 participants in this trial. Average age was 49. That's a really low age, isn't it, to be getting type 2 diabetes, with a mean duration of diabetes for 2.5 years by the time they started treatment. So what we would consider pretty new diabetes, NICE would certainly class it as that, using that phrase. And then they were randomized to one of 4 groups. So placebo, or 3 different doses of retatruide, 4, 9 or 12 milligrams, which they gradually titrated up starting from 2 milligrams using a sham dose escalation schedule to maintain the blinding. On average, HbA1c was lower with all the active treatments, with not a huge amount between them in truth. So the average reduction was 1.7% for 4 milligrams, 1.9% HbA1c reduction for 12 milligrams. That compares to a 0.9% reduction on placebo. Mean percentage change in body weight was minus 11.5% at 4 milligrams, minus 15% at 12 milligrams, compared with 2.5% reduction on placebo. So that weight loss is obviously much less than what's been reported by the company for the Triumph 1 trial, but that trial was 2 years long. This one was 40 weeks. And if you look at the weight loss trajectory here, that weight is still going down at the point at which they stop measuring it. So stay on it longer. Who knows where you'll end up, and who knows what will happen to your glucose levels as well. But the chances are both of those will be a bit lower. They didn't report on the percentage of people that achieved remissions, probably because, as we've already mentioned, they can't really call it that. But their graphs show all of the active treatment doses brought the average HbA1c down to less than 48 or less than 6.5%, with the higher doses actually generally at or under 42 or 6%, 6.0% dead, which is good news if you've recently been diagnosed with diabetes and you're only in your late 40s. Cholesterol was also lower on average. Blood pressure was also lower on average by quite a significant amount as well, 5 millimeters of mercury on average. The usual side effects as per all of the other GLP-1s and similar studies, and no significant adverse events in either group. The authors conclude that this data suggests that once-weekly retatruide could be offered as first-line treatment for early type 2 diabetes in patients without other diabetes medications. And I think we all appreciate the benefits of aiming for remission of type 2 diabetes rather than simply managing it. Of course, that doesn't necessarily require drug therapy to do it, but it's hard to do it through diet alone. It's often not a durable weight loss with that. We talked about that on the Hot Topics course last year. And while we obviously don't have longer term data on the effects of this retatruide treatment, it feels like it's going to be a big part of the future here. That's it for the research, but we're not done with the podcast just yet. So in this section of the podcast, we are going to be talking about a condition which you may have heard before, but may be entirely new to a lot of our listeners. So epidermolysis bullosa. And this has been commissioned and brought to you in conjunction with DEBRA, which is a leading charity that supports patients, clinicians, and research into this condition. And I'm lucky enough to be joined today by Dr Anna Martinez, who is a consultant paediatric dermatologist, but she's also one of the leading experts in this condition. So welcome, Anna. Maybe for the listeners, you could just introduce yourself for them.
Great. Good morning. And thanks for asking me to talk about EB, epidermolysis bullosa. As you said, I'm a doctor, a paediatric dermatologist, and I've been working in the field of EB for over 30 years. And I'm based in one of the 4 national centres where we look after people living with EB. We have 2 adult centres and 2 paediatric ones, one at Great Ormond Street and the other at Birmingham Children's. So I'm delighted to be here to talk about EB and to answer any questions that you have.
Well, thanks, Anna. And maybe we could just start off with the basics then. For those who perhaps haven't come across this condition before or maybe not very familiar with it, could you just give us a little bit of an idea about what EB is?
Yeah, so EB is a rare genetic, so an inherited condition that makes the skin extremely fragile. And by that, minor friction, even sometimes a hug or a touch, can cause blistering and wounds. And it's often described as butterfly skin. And that's because the skin is or can be as delicate as the wings of a butterfly. And although it's best known to affect the skin, it can affect many other parts of the bodies and can have a really profound impact on daily life. So the useful analogy is the skin is normally like a brick wall with mortar that makes it really strong. But in EB, the mortar is weakened or even missing. And so the layers separate very, very easily with just day-to-day life.
How common is EB then?
The prevalence affects around 5,000 people in the UK, probably more. Worldwide, probably about 500,000 people are affected.
So I guess it may be that some GPs may never have come across this condition before, but it sounds like perhaps also it's underdiagnosed because it's underrecognised, because actually we're just not very aware about this condition at the moment. Do you think then that given it's a genetic condition, it may be that some GPs might end up getting clusters of patients with the condition? So maybe from families where they've inherited it, and then you've got to see it across generations.
Yeah, absolutely. So there are 4 different types of EB, and they vary very significantly. And even family members with the same type of EB, again, their skin can vary a lot. Sometimes it goes back to many generations, particularly the autosomal dominant type, where parents, grandparents, great-grandparents have lived with, for instance, blistering of the feet and just accepted it and not been diagnosed. And it's only now where people are becoming more aware, that it's becoming more recognised, that sometimes a diagnosis is made in a child and you go back and the family says, I just lived with it. I was told that it was just my skin. I was told to get on with it, that blisters are normal. So it can be, and it often is, underdiagnosed and missed.
What age are we likely to see it presenting in?
It's a big spectrum, so you tend to find that the most severe types of EB present early, usually at birth or around birth. And those types, the more severe types, are generally the autosomal recessive types. And that presents shortly after birth with blistering or skin fragility very, very early on, or other involvement that can be very serious. The other types can present later. So the EBS that's localized can present when children start to walk, so often as toddlers. And then sometimes other types can present even much later with thickening of a toenail, for instance, in the mildest form.
Okay, so it's likely that we're going to see this in childhood, but very possible for some perhaps where the condition is slightly less severe that it could be that it's been missed and the first presentation is in adulthood, and we need to be thinking about that quite carefully as well. You mentioned that this is a condition of blistering skin, but perhaps you could just give us a bit more detail about the clinical features and what might help us differentiate from other conditions that also present with blisters.
And although we can say, yes, sometimes it can be, present in adulthood, the vast majority presents in childhood with some problem with skin fragility or blistering or thickened nails, sometimes missed or sometimes picked up late because the diagnosis has been unclear. They've seen a lot of doctors in order to get the diagnosis. But I think with education and understanding, it is possible to try and be more alert at the early signs.
It's interesting you were mentioning about having seen a lot of doctors potentially before they get their diagnosis. I suspect that many GPs and other primary health care clinicians, we might see a patient who's got some kind of blistering rash and that may be beyond what we're able to manage in general practice. And so, of course, we're then going to make a referral. But the normal pathway, of course, would be that we make a referral to the local dermatology service. And it sounds like that's not ideal then for EB.
Absolutely not. I think we're very lucky in England to have a highly specialised commissioned service for epidermolysis bullosa. As 2 adult centres, one in Solihull, one in Guy's and St Thomas's, and as I mentioned already, the paediatric at Great Ormond Street and Birmingham Children's. And I know that all 4 centres would happily accept a referral for a blistering condition where it was uncertain, so it wasn't impetigo or an obvious infection. We would rather over-refer the patients and see them. And we could always offer advice if we didn't think it was obvious to be EB, or suggest to refer to your local derm centre. But we would never, ever reject a referral for query skin fragility or blistering or just an unusual appearance of the skin.
With that referral pathway, how would we normally approach that from general practice? Would we make a direct referral for people to come to see you in clinic, or do you accept sort of like a bit like advice and guidance referrals where people might send in the clinical picture with photos attached? What's the most useful thing for you if we are referring?
Direct referrals with pictures is often really helpful. We absolutely accept referrals direct from GPs. In fact, we would encourage it if that speeds things up. We can triage, and if we don't feel that it's we're the right place, then we would communicate back.
Great. Okay, thanks. If then a patient has gone through that process and you make a diagnosis of EB, what kind of treatments might they be offered then?
The treatments that we offer today are much, much better than they were even a decade ago. But even today, treatment really is still focused around sort of specialist wound care, pain relief and itch, preventing infection and supporting holistically growth and nutrition. Often this is a multisystemic condition, so it doesn't not just affect the skin, it can affect in the severe forms many organs in the body. And we have a large team of specialists in these 4 centres that are absolutely equipped to try and manage and give the best quality life possible for all the patients. But some biggest advances now, we're beginning to have some treatments that are beyond symptoms. So there are new therapies that are developed. They're sort of targeted therapies, some very sophisticated topical therapies that can temporarily correct the genetic spelling mutation in, for instance, recessive dystrophic EB. So gene therapy is approved in the States, and in Europe it's going through the NICE evaluation at the moment. And there are some new approved treatments for wound healing called Flucives. So at the moment, we're waiting to get these new therapies that could potentially sort of alter the course of EVB itself. But we don't have a cure. We're very far from that at the moment. But there is worldwide global efforts to try and get better treatments faster for patients.
And I guess that just highlights the importance of us trying to identify these patients and get them to the right place so that they may hopefully get access to some of these more modern treatments, which absolutely can have a huge impact on their quality of life.
Yes, for sure. As I said, this is such a complex condition, and even in the mildest forms, if you're unable to go out with your friends, go to the shops because your feet are just too painful, it has a profound effect on daily life.
So it's hard to appreciate, I think, the significance of these conditions sometimes when you're just talking about it on a podcast. I think visually you can start getting a much clearer picture of this. And so I'll put a link in the podcast description through to the DEBRA website. They've got some really powerful case histories on there. So children who are trying to live with this condition, you can see the images of their skin which they're having to manage, and it really is quite shocking. Really can be a really unpleasant condition. And also we've done a educational module on MB Medical in conjunction with DEBRA, which goes into a lot more detail about epidermolysis bullosa. So if you do want to know, for instance, a bit more about the different types of the condition, if you want to know a bit more about how to perhaps differentiate EB from other blistering skin conditions, then that's all in the module. It's free. Just click through from the podcast description and you'll find it. Dr. Martinez, thank you so much for joining us on the podcast today. It's been great to talk to you.
Great. Thank you very much.
Well, I hope you found that interesting. Who knows, you might find your first case of epidermolysis bullosa off the back of that. We'll be back with a podcast in 4 weeks' time. More research to come, I'm sure. In the meantime, you can always get in touch. So hottopics@nbmedical.com on the email. We're on Twitter, Facebook, or X, whatever you want to call it, all the social stuff. You can find us there too. And in the meantime, hope it's good weather for you. Enjoy the summer. Take care. Bye-bye.